Warm welcome to this latest edition of our webinar series at the NHR supported Incubator for AI and Digital Health. I'm Jeff Hogg, a clinician scientist working at University Hospitals Birmingham as part of the Incubator team. And for those of you who haven't joined us before, here at the Incubator, we host a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare. And this demand-led webinar series gives us the chance to invite experts along to share their work and insights in key areas with us and give us an opportunity to dig into these exciting topics and bounce some ideas around and grapple with some of the challenges that we experience across the sector. So the format of these sessions holds that in mind. I'll soon be able to be quiet and hand over so that we can enjoy the presentation from our speakers today. But you'll notice there's a Q&A button at the bottom of the screen. So as we hear the presentation, do feel free to tap away to get your questions and comments down there. But we'll wait until the end of the presentation to dig into them. So I'll either voice the questions myself or be able to invite you on to speak to them. And we'll have ample time for those at the end of the session. But if we don't manage to get through them all, please don't worry. As I mentioned, we're really keen to hear the kind of questions that people hold in their mind and try and address them with the program moving forward. So they are really helpful. Please don't let it hold you back adding extra questions. Just as another kind of housekeeping note, we'll also be recording today's session and we'll host that on our newly updated website if you haven't had a chance to have a look at that. So you can rewatch or sort of refer it on to any colleagues or contacts if you'd like from there as well. Great, so that's all of the housekeeping stuff put to one side. So that means that I'm now able to introduce the team of researchers who've kindly joined us today to share insights from their work evaluating the implementation, experiences and impact of AI in chest diagnostic services. We're lucky to have three of the team with us today, but I'll start by introducing Dr. Angus Ramsay, who's the Principal Research Fellow at UCL Department of Behavioural Sciences and Health, the Deputy Director of the NHR Rapid Service Evaluation Team, and Lead Investigator of this mixed methods evaluation. So I think that's enough from me, and it gives me great pleasure to hand over to you, Angus. Thanks very much for joining us.
Oh, hi, Jeff. Thank you very much for the introduction. And just on behalf of my colleagues, we're really happy to be here today. I'm very happy to be sharing some of the lessons from the work that we've been doing. Now, I'm just going to bring up our slides. I think that should be us full screen. Okay, so yes, I'm here to talk about our current work and recent findings. Sorry, I've just lost my window.
We can see it looks great for us, I'm afraid. Hope you find it soon.
I might have to stop sharing. Sorry, unless I can see it. Oh, yes, that's it. Sorry about that. Minor tech fail. I'm not used to Zoom at the minute. I'm more Teams. Anyway, yes, here to talk about the findings from the first phase of our rapid evaluation using mixed methods to look at procurement, early deployment of AI for chest diagnostics. So let's just on. So as a lot of you may be aware, past research has suggested that AI for chest diagnostics may help such services in many ways, such as speeding diagnoses and supporting accurate diagnoses, and hopefully reducing pressure on the workforce and associated costs. But as we'll be discussing later in more depth, there's limited evidence on real-world implementation of tools of this kind, considering how different stakeholders experience it, the effectiveness of these services, of these tools, and the costs associated with putting them into action. As part of our work, so we're part of the NIHR Rapid Service Evaluation Team. We've been commissioned by NIHR to look at exciting innovations in any area in health and care services. We were approached to look at this major program launched in June 2023 by NHS England. Sorry about that. Called the Artificial Intelligence Diagnostic Fund, which provided £21 million to support 11 imaging networks across the English NHS, covering 66 NHS trusts. The aims of this programme were, in the immediate term, to increase service efficiency and effectiveness, hopefully reduce backlogs, and in the longer term, improve diagnostic services and waiting times and reduce burden on clinicians. The programme that we were looking at was based on a network-led procurement process and sort of trust-level deployment supported by these networks. Just going to move on to the next slide. So our overall aims were to study the procurement, deployment, and early implementation of AI for test diagnostics, look at factors that were influential in this, and consider settings and data sources for further evaluation, some of which we're now leading as part of our second phase. So what we're presenting today are the findings from phase 1, which ran to the end of last year. And these have now been fed into our second phase, which is currently running. Just want to emphasize that in terms of our brief, we weren't meant to be looking at the sort of relative accuracy or effectiveness of specific AI tools. So in terms of our questions, we were interested to find out how stakeholder perceptions and experiences might be evaluated, how services can measure the impact of deploying AI tools, both on patients and the wider pathway, and what the key cost components for deploying AI might be. And we looked at those through a rapid literature review, which we'll be speaking about shortly. We also were looking at how the AI tools were procured and deployed both at network and trust levels. We looked at which factors influence implementation of these tools at these levels, and we explored a range of stakeholder experiences, including network staff, hospital staff, and AI suppliers. I'm going to hand over to my colleague Rachel now, who will talk through the findings from our rapid evidence review.
Thanks, Angus. Hi, everyone. My name is Rachel Lawrence. I'm a qualitative research fellow based at UCL and one of the qualitative researchers on this project. And before we started alongside our empirical work, we wanted to know what was already there in the existing evidence and what the key evidence gaps were. So as Angus mentioned, we conducted a rapid systematic scoping review of the evidence. Next slide, please, Angus. Thank you. So we were focused on the use of AI in diagnostics for radiology, and we broadened the scope of the review to focus not just on chest, but all conditions, and we didn't have a geographic focus, so all papers were included were those worldwide. In total, we had 140 studies included in our review. These studies used a wide range of methods to evaluate AI diagnostic tools in radiology. So studies evaluating implementation, which there were 7 of. Sorry, Angus, can you just go back one for me? Thank you. They all used qualitative design, so they used case studies, interviews, documentary analysis. Studies evaluating experiences and perceptions mainly used surveys, but also at times used qualitative interviews. Studies evaluating quantitatively evaluating impact were measuring diagnostic accuracy, effect on time and workflow, and effect on clinical decision-making. And studies evaluating cost effectiveness included measures of retention time, mortality, and withdrawal time. And a key point to really highlight is that of the studies analysing effectiveness and cost. Only 23 of these actually evaluated AI in a live pathway. The other papers that were included simulated a typical workflow. Next slide for me, please, Angus. In terms of our findings, so for implementation, only 4 of the studies actually focused on the process of implementing AI in a live pathway. The remaining papers within this topic focused on experiences of implementation. So when they were focused on the process of implementation, AI was mainly used as an assistive tool, and implementation involved integrating AI into existing radiology systems. And then within these papers, they often reported on the key barriers and facilitators. So some of the key barriers were the high technical demand of integrating these technologies and the limited evidence guidance to support that implementation process. Facilitators included having AI champions and experts, and also, although it was the high technical demand, actually integrating into these existing systems that were familiar to people could also be a facilitator. In terms of our evidence on experiences, so we only had papers on staff and trainee experiences, so none of the papers within our review were focused on patient or public experiences of receiving AI-based care. From what staff and trainees reported, they did find AI to be a usable tool, to be helpful in terms of time and workflow and diagnostic accuracy, but there was mixed evidence. So staff reported that they did have concerns around the limited evidence, the knowledge gaps, the potential risks of false positives, and also the risk of creating longer processes and then actually reducing efficiency, even if the aim was to improve efficiency. Next slide, please, Angus. And then focused on perception. So this was a huge amount of our review papers. So 74 papers looked at perception. So this is just what different groups of stakeholders think about using AI in radiology for diagnostics. So in terms of their general view, staff, patients and carers generally viewed AI positively. But there was a very consistent view that AI should not replace humans, and there was a real importance placed on having that continued human input. Trusting AI was often reliant upon having that human oversight, but also transparency and explainability in how AI actually makes decisions, and this was particularly important for patients and members of the public. Some staff felt that AI would change the radiology profession, and this could be with upskilling and potentially enhancing roles, but there was also a risk of reduced autonomy with increased use of AI. And then when thinking about the factors that will influence AI being used in radiology for diagnostics, there are lots that were mentioned, particularly the lack of knowledge and training, the lack of organisational readiness and infrastructure to actually be able to support AI to go into place, the risk that AI potentially could lack human connection and that empathy that you might develop when your profession, healthcare professional, is human, the importance of transparency, the importance of expert leadership, and also a willingness for people to learn more about AI in this context. Next slide, please, Angus. So my amazing quantitative and cost colleagues helped with the review to look at the quantitative and cost evidence. So I will read their findings, but any question, I'm sure Kevin and then Chris via email will be able to help. But in terms of the quantitative papers, they demonstrated improvements in diagnostic accuracy and reductions in interpretation times through these papers, but the improvements in workflow efficiency were variable, and these effects were influenced by the technology and the condition. And there was also very limited assessment of health inequalities. In terms of cost effectiveness, there were only 6 papers that looked at cost effectiveness. 5 studies did demonstrate that AI was cost effective, but 1 study did not, because they found that more invasive treatment approaches actually resulted in higher patient costs over the patient's lifetime. So just to conclude before I pass over to Angus, through this review of the evidence, which included a lot of papers, we concluded that there were evidence benefits of using AI, and that people are generally quite open and positive towards the introduction of these technologies. But actually, we don't know enough yet. And particularly, we don't know enough about how AI can be put into practice and the impact that it can have long term in real world settings. So this was just a snapshot, but in perfect timing. Our review paper has actually just been published in the Lancet eClinical Medicine, so I can link that in the chat if people want to read more. But I will now hand back over to Angus.
Just unmuting myself there. Thanks, Rachel. So yeah, just moving on to the empirical work that we did, and this was broadly based on a largish number of interviews that we did across multiple networks and a small number of trusts based within 3 of the networks that we were studying. The interviews that we conducted and the observations that we conducted were attended by qualitative and organizational researchers, but also quantitative and health economic researchers, so that we could have a really rich discussion of the issues arising in procurement and deployment of these tools. So some of the key findings from this work, just first of all, in terms of the aims of the tools that were used, they varied a little bit. So in the majority of cases, the tools were being used on X-rays, but in one case that we looked at, they were being used purely on chest CT scans. We found that they were being used for multiple functions. The initial idea was that they'd be focusing on lung cancer, but rapidly over the course of the development of this program, it emerged as being used for all sorts of other things that came up during the procurement process. So not just lung cancer, but other diseases and conditions such as sepsis and TB, spotting misplacement of nasogastric tubes, and identifying chest fractures. Another key function was prioritization of critical cases, essentially bringing scans to the front of the queue for assessment by the radiology teams. There was also potential to act as a second reader, though that hadn't been activated at the time when we were doing the work. And there were also obviously variations in the chosen supplier. And so the bottom line with this was that local networks and staff had to make lots of decisions to tailor the AI to their local context and local priorities. We also were interested to look at where the AI sat in the patient pathway. And so this schematic basically summarizes the overall pathway and where AI fitted in. So patients were referred in and their scans were assessed by AI if they met certain eligibility criteria that varied from network to network. The scan was then uploaded into the local PACS and RIS systems. At that point, the eligible scans would be processed by the AI tool, which would produce its report and prioritization if that was activated in the area. The scan would then be provided to the reviewer, who would review the scan independently and make their decision, and then check it against the AI suggestions, assess whether they agreed or disagreed, and follow local procedures for dealing with any discrepancies. And then once that had happened, the patient would pass on to their next stage of care. We found that there were a number of variations in how things were working. So, for example, eligibility criteria. In some areas, they were only processing patients who'd been referred by GPs. Some places they were looking at outpatients only. Some places were discussing the possibility of looking at scans provided through the emergency department. We also saw variation in who was reviewing the scans. So in some areas, it was radiologists only, and in other areas, it was a combination of radiologists and radiographers. Here are the key stages that we were able to look at. So we weren't really able to look very much at deployment and practice at the end of things, and we'll come back to that. But basically, there was a lot of work at the outset where local networks engaged with their local trusts to ensure that the trusts were happy to be part of this process. So it was entirely voluntary. Networks had applied, but local trusts could say that they didn't want to be part of the program. And in a small number of cases, trusts did withdraw from the process. In terms of procurement, there was a lot of work to do in terms of preparing the tender specifications, dealing with processing the applications, scoring these and making a selection for the preferred supplier, and then managing the process of communicating these decisions and signing off the contracts. An important point here is that the timeline started to diverge from the anticipated timeline quite quickly. So when this was all launched formally in October 23, the national programme anticipated that contracts would be getting signed sometime in November. In practice, we found that contracts were being signed between December of 23 and March of 24. So a bit of slippage there. In terms of preparing for deployment, we saw a number of key factors in progress of preparation. So a big task was obtaining local information and patient safety governance approvals and navigating these processes. Another biggie was tailoring the tool to the local setting. So integrating with local IT systems, PACS and RIS systems, which commonly varied from trust to trust. So multiple steps of trying to adapt the AI tools so they fitted in with local systems. Another major task related to this included training up relevant staff to use the tool appropriately. Now, the anticipated timeline for this was that the preparation for deployment would happen over November to December 2023. But in fact, that began January 2024 onwards. And in practice, we found that getting services into practice and getting through that preparation process, it had been hoped that services would commence work with AI in clinical practice from December 23. By November 2024, only 24 of the 66 were actually operational with the tool in clinical practice. I'll just move us on. And I should say that now it's over 40 of these trusts that have at the last check. So a couple of other themes that we wanted to explore. We thought it was important to dig into issues around equality, equity, diversity and inclusion, and engagement with patients. We found that EDI was seen as a key issue in many of the networks that we spoke of. They felt that the AI and its potential sat well with the Trust's broader strategies to focus on local health priorities and variations and deprivation. And AI had potential to address some of these variations locally and address inequalities. EDI was central to all of the specification tools used during the procurement process, but very seldom was seen as something that made a difference to which tool was chosen. So very often it would be scored quite similarly or not weighted heavily enough to make a difference. We saw when we talked with people about how they might be able to use AI to address inequalities, there felt that it seemed that there had been limited consideration at that point during preparation for deployment, the extent to which that would be possible and how that might be done. We saw very varied approaches to how services might communicate with patients about the use of AI. We found at one end of the scale, we were aware of a trust of a network that was planning to communicate directly with patients. They weren't quite sure how they were going to do it. Others took a more passive approach, so they would share information if it was requested by patients, or they would put leaflets out and put up posters. And we also found that two networks were not actually planning to inform patients at all about the use of AI. Continuing with the theme of procurement, one thing that we found was that it's a very complex area and it's quite novel for healthcare services to talk about procurement of artificial intelligence. So it's really important that these teams were not just representatives of the healthcare team or the radiologist team, but also drew on information governance and IT experts, procurement experts, dedicated procurement experts as well, to ensure that the tools were being procured appropriately. The local imaging networks were central to leading the procurement, drawing together these groups to make the selection process. We found that more established networks were more effective at engaging the right services and the right stakeholders to do this work. We found that there were sort of national meetings that brought together the imaging networks, and we found that a sort of community of practice evolved, which basically was, we saw the various networks sharing learning and sharing good practice to try and help the teams the network teams who might have been facing common obstacles, and a lot of discussion about shared challenges. One thing that came up in the discussion of the procurement was that a lot of local teams who were doing the selection process were quite frustrated that they weren't able to see the AI tools running on their local systems. They saw a generic example of how the tool worked, but it didn't necessarily reflect their local system. We also reflected that, I mean, basically, as you saw, there was a significant amount of time devoted to the procurement process, a lot of duplication of effort. And there may be an argument for considering a more national approach to procurement of AI tools to free up network capacity to focus on facilitation of deployment. Talking about preparation for deployment, as discussed previously, there were quite substantial delays in getting through this process. The governance, as I mentioned, the information and patient safety governance process is really important, but they did take time. They were very challenging for networks to process and ensure that they got through the permissions at a trust level. So in each case, this couldn't be done across the network. You had to get local governance permissions on a trust by trust basis, and each trust had its own processes and its own forms, again requiring lots of adaptation. Some potential supports for completing the governance process. We felt that there might have been value in greater expert guidance at a national level on how this process might be done and how certain challenges might be mitigated, ensuring clear points of contact right the way through the system, but especially in terms of accessing the relevant staff within each trust. While there were timelines, we felt that there might have been a need for clearer timelines around how these processes would be gone through, and perhaps more established resource templates in relation to understanding the resources involved in implementing AI. Another thing that we noticed was how important it was to get support from supplier teams. So the AI suppliers were extremely committed to supporting getting through local governance processes and integration of the tool with local services. In addition, we found that local clinical champions were key to navigating some of these challenges. So local clinicians, for example, knew who to speak to and were able to link people up with the relevant committees. Early staff engagement was important to addressing natural concerns that might have been raised by local staff. Many staff that we spoke with indicated that they didn't know very much about AI, the processes involved with it, and so on, and therefore would have valued more training and more education about this side of things. A huge one for us was having dedicated project management. Some trusts and some networks did dedicate some resource to having professional project managers supporting and leading the process, and others did not. And we saw very significant differences in the progress of preparation for deployment in areas that did and did not use that. I'm going to hand over to Kevin now, who's going to talk through some of our reflections on outcomes.
Thank you, Angus. Just to introduce myself, I'm Kevin Herbert. I'm a health economist working out of Cambridge University. My part in this project is covering the health economic aspect of the mixed methods study. I'll also be speaking on behalf of my colleague Chris Sherlock-Johnson, who unfortunately can't make it today, in covering the findings in relation to the quantitative data aspect of the phase 1 project. In terms of those two parts of the project, they're kind of related with kind of several overlapping areas. Chris's focus was in terms of they both focused on a process of mapping out the landscape of data relevant to the more kind of refined quantitative aspect, but also from my point of view from the health economics side in terms of understanding the landscape, the data availability, evidence gaps, technical practicalities when it came to identifying and obtaining particular pieces of information which will be able to inform the deployment of AI across the clinical pathway, performance metrics, outcomes, etc. So that's just a quick summary of how our two areas of the project relate. So in terms of findings in relation to outcomes and sources of data from the AI deployment. So when it comes to the main source on process measures and aspects like turnaround times, then the local radiology data sets, the RIS and PACS systems are the primary sources for those. Kind of which one specifically would depend on the local infrastructure. But those were the primary sources in terms of obtaining information specific to the processes. When it came to identifying the kind of the process of the clinical pathway, the care pathway, so from initial testing through to treatment, so from the front end, kind of patients coming in from referrals through to their exit onwards on the care pathway. In terms of linkage across that pathway, that was that linkage of data was only available in a few sites, and to varying degrees, some or to varying degrees, some or larger parts of that data potentially were time consuming to bring together. So either from the point of view of kind of proceeding to the linked data, or actually compiling specific metrics from the data that was available. So where you've got data which requires a degree of manipulation to kind of refine it into a form which can be utilized for a specific data point or data set. So when it comes to information data from the AI suppliers, obviously they're the kind of like they were able to outline the availability of data in terms of post-market surveillance, which it seems like there's a question already in the Q&A about longer term use. So in terms of the kind of the algorithms and the performance and the kind of like following how the data is processed and kind of how the AI is handling that data and the outputs, the platform tools and the suppliers themselves are able to cover most, if not all, areas of that. And then more widely, in terms of kind of piecing together the overall landscape, the kind of as you might expect, the more traditional kind of national data sets would be able to provide particular data when it comes to hospital administrative data in terms of identifying kind of patient outcomes or kind of instances where the patient comes into contact in relation to that. So one aspect would be the instance of, say, of representation of patients from a misdiagnosis from whichever source, with or without AI, through a hospital setting, referrals via A&E, as Angus mentioned before, and then also the diagnostic imaging database as a key national data set when it comes to data specifically around that section of the care pathway. So in terms of the considerations on that landscape, as mentioned just now, the availability of data, the degree of granularity at which it was available, and the potential for linkage were kind of issues which raised themselves, and depending on the locality, some or all of those would be an aspect when it comes to being able to collate data across the care pathway. In terms of the wider environment in which the AI deployment sits, currently there are a number of trusts which are operating at various degrees of backlogs, and so there are concurrent interventions aimed at addressing that, and so being able to disentangle the effect of the AI deployment from those concurrent interventions when it comes to reducing backlogs is tricky and would require a degree, a notable degree of work to be able to tease those apart. The variability of interventions across different sites, and the baselines for those different sites means that being able to generalize in terms of findings with the samples we were able to work with on this level could be quite tricky. So when it comes to my part, which I'll come on to in terms of the health economics, the approach is looking at it from a kind of an overall deployment view rather than specific trust level evaluation as such. So in terms of that, being able to generalize from the sample that we have to a specific a different site which might have different infrastructure and implementation and deployment approaches may be tricky. And then the ability to kind of establish comparators when it comes to discerning what the effect of AI is when it comes to kind of the deployment versus what went beforehand. Thank you, Angus. If we could have the next slide. There we go. So there we are. Wonderful. Thank you. So moving on to the health economic part of the phase 1 project. So this was a kind of a discovery exercise in terms of understanding the kind of what the key costs and resource uses would be, and what the available data would be around that, and the kind of feasibility of obtaining some or all of that. So it's broken down into kind of 3 key areas in terms of the key costs, the staff capacity aspects of the deployment, and then kind of understanding any potential changes in productivity that may come along with the deployment. So in terms of costs, the approach as specified earlier, in terms of not looking and evaluating one specific AI platform, we'll be looking at an evaluation aggregated across the sample. So as you might understand, in terms of anything we would do on a platform level would be commercially sensitive, and we're working with the trusts and the AI suppliers in terms of an agreement and an understanding that we're looking at it from an overall deployment point of view rather than an evaluation in terms of individual platforms. That said, the work we're doing hopefully lays the groundwork and a framework for kind of more specific evaluations to be performed in future by whoever would wish to do so. And hopefully the kind of considerations, the information we find will facilitate that process in the longer term. So in terms of the costs and the key costs that were identified, so in addition to the cost for the AI platform itself, a number of additional costs that we identified, not least the costs around the integration of AI into the platform itself. Depending on the location, the locality, the site may have an in-house IT support provision. Alternatively, you've got costs which may occur where that's outsourced, which would be differential. And in terms of costs around the implications of kind of implementing AI, the potential for changes in how the services implemented. So for one instance here would be a facilitation of using the AI platform as part of a reporting from home for urgent and out of hours reporting facility. And so therefore the required infrastructure to be able to facilitate that would be a cost, which would be an additional cost, which would be incurred if that was to be integrated into a particular service at a particular site. When it comes to staff capacity, obviously potential changes in terms of the numbers and type of staff, so the nature of the reporting clinicians, the number of those that are required, when it comes to the AI support and potential improvements in kind of productivity when it comes to the AI, the kind of the effect of the AI support. Costs around the training resource demands. So there were different approaches. Some sites were progressing along a kind of like a super user format. So they would have a member of staff or two who would be kind of early adopters and then would roll out training to kind of their colleagues more widely. And so that's a resource demand which potentially could, would be taking them away from their kind of not regular duties for a period. And then the implications of service performance, data extraction. So again, it differed across sites, but some would have a kind of in-house data analysis staffing function, and in others that data extraction in terms of monitoring and setting up the kind of longer term performance auditing, performance monitoring and auditing functions were performed by somebody for whom that was an additional kind of responsibility, and so therefore there were potential differences in costs around that. In terms of productivity, as you might expect, the automation and prioritization and potential for same-day reporting may assist with improvements there. So in terms of the ability to turn reports around, even to the point of referring patients onwards on the same day. And so in order to kind of ascertain that, kind of looking forward to phase 2 of the project, we'd be looking at obtaining what we could in terms of understanding what those improvements might be through surveys or aggregate reports around in terms of time savings, and collection of routine service performance metrics. And in terms of understanding some of those aspects more widely, the kind of the potential for linkages with patient records more generally, and as discussed in the previous slide, some of that may come with issues where those linkages may or may not be possible. So they were the key findings. In terms of phase 2, we're going on to kind of explore and put into practice, collating and actually putting those together in terms of a degree of an evaluation from the health economics side. So that covers our section. If I could hand back to you now, Angus.
Thanks, Kevin. That's really helpful. Thank you. Okay, just moving on to the sort of emerging lessons from this work. So we talked quite a bit about the amount of time that things took and some delays in implementation. So a key lesson is the need to plan in sufficient time or build in sufficient capacity, for example, staffing and other resources, to ensure that these processes can be run sufficiently quickly. Recognize that there may be some trade-offs if services try to create a large platform that might permit more automatic deployment of tools. Would involve a lot more time to set up a platform like that in advance. Really important to have early and continued stakeholder engagement at every level, from national down to the front line, including the AI supplier and evaluators, to support key processes, and communication collaboration right the way through, really important. Sufficient resourcing was vital. We found a value in dedicated project management, progressing preparation for deployment, but also considerations around the time that clinicians have to give up in order to support the work, and the efforts involved in collating data to support evaluation, very much as Kevin was discussing a minute ago. Networks played a really important role in implementing these tools, supporting through project management, providing national level advice, driving changes, and facilitating network across, facilitating learning across the trusts within the network. Another really important point, we found there were real gaps around the patient voice and engagement with patients, and more to do in terms of considering equality, diversity, and inclusion. And we think, moreover, at the minute, we're in a situation where a lot is being driven towards putting AI into practice, but still quite a lot of gaps in what we know about how processes like this work. And therefore, some of these gaps around patient experience, around implementation and procurement, and so on, need to be considered further and factored into future policy and evaluation plans. A couple of key limitations. Because of the delays in implementing the AI tools, we couldn't actually look at the full deployment of AI tools in practice and how they were running on a day-to-day basis, which we've been hoping to do, but we didn't have time in our first phase. Also, because of our rapid time frame, we weren't able to get the permissions in place in order to interview patients and carers, and we weren't able to recruit people from across the wider system. Now, we're addressing all of these gaps to a degree in the current research that we're doing. We are now focusing on implementation, adaptation, sustainability of AI tools in the chest diagnostic setting. We're going to be looking at the real world impact on care delivery effectiveness and cost effectiveness. And we are going to be able to look at the patient and carer experiences facilitated by AI. Obviously, in our addressing that, we don't fill these gaps fully. Other research has to be doing this too. But we are focusing on these in phase 2 of our evaluation, which is currently running. So, key conclusions. In terms of implementation and experiences, AI may positively impact diagnostic services. We found that AI was being deployed and implemented in different ways in terms of its aim, the approaches taken, and the way in which the pathways operated. Implementation is a complex social and technical process, and therefore takes a lot of time and resource. A number of factors, obviously time and resource, were important barriers to this. We found that important facilitators were good engagement with stakeholders, clinical leadership, support from networks, project management, and so on. We found that many networks didn't really have expertise in these processes of procurement and support and deployment at this scale. And so there was a lot of learning on the job, given this innovative nature of the task. In terms of measurement and evaluation, we found that there's limited real-world research on implementation and use of AI tools in radiology. Therefore, it's hard to ensure that current implementation, being driven by policies, are actually informed by sufficiently robust evidence base. We feel that with this work begins to outline some of the ways in which evaluation of effectiveness and cost effectiveness might work. But there are still real challenges in relation to the type of data that are available and the infrastructure existing to support access to these data. This is just a summary of our team and our funding. And obviously, we really thank everyone who took part. And if you want to find out more, we've got a couple of QR codes to link through to our relevant pages. And yes, thank you so much for listening. We've got a little bit of time for Q&A and really looking forward to discussing further. So I'll stop sharing now.
That was brilliant. Thanks so much, Angus, Rachel, and Kevin. I think that's a really rare insight into how an AI intervention is landing across different provider organizations, as you say. We've already got some good questions coming in, so I'll hop straight to those. I'm afraid that they come down as anonymous thanks to Zoom. So I'll try and speak to them, and do put another comment on if I'm doing a disservice to whoever put them out there. But it may be challenging given where you were up to, as you say, with not many of the interventions actually going live. But did you get a sense of how the performance of tools varied between institutions, or how it began to drift over time? There's a nice example that's been raised by one of the attendees talking about sepsis algorithms in the US context, and how they're quite widespread now, but because of the kind of resource requirement of retraining and monitoring, it started to affect whether or not people are thinking that they deliver value. As I say, maybe something that was a bit early to see, but be interested to hear if you had any thoughts or insights.
You're right. It's a little early for us to say. We are about to begin that data collection, and we will be able to look at how things are adapting and shifting over time. But it sounds like a very relevant study for us to look at if that's been published, and we'd be keen to learn more about it.
Thanks, Rob. Kevin, do you come in?
Yeah, and thank you for the question. It's a very good one and a very salient one. I think one of the mitigations I think will come in terms of the regulatory requirements around AI implementation in the UK, in that there are quite strict requirements in terms of effectively an algorithm lock. So AI suppliers are the kind of the AI that would be deployed wouldn't be free to kind of learn on the job, if you like, and drift, as I think the question is alluding to in terms of the USA case. So any kind of updates to the AI algorithm would require a kind of pre-release I'm trying to think of the word, but a pre-release validation before it was actually permitted to go into service. So in terms of the potential for that AI drift kind of in real-time deployment, I think that'll be mitigated by that requirement. Then I guess, potentially there could be changes, population changes or changes in terms of, on a clinical basis, which may mean that that process of AI learning has to go on in the background to then account for the fact that the performance may change over time, or indeed they're able to train the algorithm to perform even better on the basis of the sample sets they're able to kind of the larger sample sets as time goes on. Hopefully that answers that question.
Thanks very much. The second question is kind of in a related space, as the solution to this drift, or another solution. around post-market surveillance. And I wonder, I know you had a good insight into the way that different organizations were preparing for deployment. Did you get much of a sense of how different provider organizations were planning surveillance or not, and how that differed? Perhaps what drove those differences?
So again, we'll be finding out more about how things are happening in practice shortly. But what we did see were lots of discussions about how that might work in practice as people anticipated deployment. So a lot of the tools that were being used were operating with a very standardized interface, and there was basically an option for clinicians to indicate whether something was right or wrong and provide feedback on the scan. My understanding, certainly in the cases that I was observing, was that the completion of this information was likely to be voluntary, and there might well be variations in awareness of the potential to do this. But certainly the information flowing from that was seen as potentially really important to understand how things are working post-implementation. And we also saw a lot of discussions about Kevin mentioned the super users, sort of sharing updates with the AI supplier on cases that definitely were not working and cases that were really good examples of how the AI tool was making a difference. But as I say, these were plans, and it will be really interesting to see how these things are happening in practice.
Yeah, thank you. And I'll just try and squeeze in one more question, if that's okay. About, I know you were speaking about the kind of evidence gap around, well, real world evidence gap here and elsewhere in AI, and that the setting's a little bit different here because all of your sites, I suppose, are already committed to the deployment. So in some ways, the decisions have been made. But did you build a sense working with the different kind of leads and decision makers in these organizations of what forms of evidence would be most compelling to them, or what it was that they were looking for to make them think, yeah, it's a good idea to implement this, or this solution is working?
I mean, certainly thinking back to the discussions we had, a lot of it was about what you would expect. It's basically, is this serving the mission of the clinicians? Are we providing a safe service? Are we providing an effective service? Is this hopefully going to improve efficiency? I think those were a lot of the big priorities that we saw being discussed in project meetings and so on. I might see whether, Rachel, do you want to feed in at all, given that you've just completed the evidence review and that's a wider picture of things?
Yeah, I'll be really quick. I think a lot of the important priorities as well is how should they be implemented and what should be taken into consideration when you're doing that implementation process. So what potentially makes it harder, what could potentially make it easier, and also how to kind of work with the existing radiology systems that exist. So you're not asking people to learn a whole new system with something that's then meant to improve efficiency. But I'm very conscious of time, so I will stop there.
That's a really helpful insight, and thanks so much for sharing the links to the systematic review. That's brilliant. I'm looking forward to diving into that. And thank you for joining us. I think that brings us to time, really, but I really appreciate you coming along and sharing this fantastic work. And I hope we can hear about stage 2 at some point down the track. It sounds like it's going to produce some really interesting findings.
We'd be thrilled to. Thank you.
Yeah. So thanks for joining us, and thanks for everybody for coming on and dialing in. And just briefly to flag that our next webinar's on Wednesday, June the 11th, and we'll be joined by Professor Alicia Rudnicka from St. George's, who'll be speaking about the program of evaluation of AI diabetic retinopathy screening services that she's co-led. So thanks once again, and I hope you get to enjoy the sunshine and what's left of it. Have a good evening.
Thank you.
Thank you.
Thanks.